Hi guys. So question 141, diseases of intrahepatic and extrahepatic biliary tree. So now whenever we're talking about, intrahepatic and extrahepatic biliary, the hepatocytes basically produce the bile and secrete it into the bile canaliculi. From there it flows into the canals of hearing, ductules, and finally into the portal tracts, from which it is seen via the hepatic ducts to the gallbladder or to the common bile duct, right? Now the function of bile, emulsification of fat in the small intestine, and excretion of water insoluble weight like bilirubin, cholesterol, xenobiotics, or steroid hormones. Jaundice occurs when bilirubin levels in the blood reaches more than 2.5 milligrams per deciliter and are disposed in the skin and sclera. Now, when you talk about bilirubin metabolism, so this is basically kind of like an introduction. So we talked about RBC turnover by the splenic, we can say macrophages. Heme is converted into a biliverdin, loaded onto albumin into the blood and flows to the liver, conjugated to glucuronic acid and is secreted into the common bile duct to the bile, and then we can say conversion of conjugated bilirubin to we can say urobilinogen and stercobilinogen by the gut bacteria, fecal excretion of stercobilinogen, and blood reabsorption of urobilinogen leading to excretion in urine and recycling in the liver to bile. Now, first of all, this is the content that we'll be talking about. So we're talking about the diseases. So we're going to talk about cholestasis, obstructions, cholangitis, right? Atrasias, especially cholangitis is very important, especially primary biliary and primary sclerosing cholangitis and the differences between them. So let's start with cholestasis and jaundice. So when I talk about cholestasis is basically an impaired production, secretion, or outflow of bile. Now there can be different types. So the classification is important in this case. Talk about like non-obstruction and obstructive. Now non-obstructive can be prehepatic or hepatic. In this case, there's increased hemolysis, liver damage, increased estrogen, and Dubin-Johnson syndrome. Plus, it can be also a part of Crigler-Najjar syndrome, in which there is poor conjugation, and Dubin-Johnson syndrome, which is poor delivery. Then we have obstructive, which can be intrahepatic or extrahepatic. Intrahepatic is normally due to hepatolithiasis or primary biliary cholangitis and liver tumor, whereas extrahepatic would be cholelithiasis, primary sclerosing cholangitis, biliary atrasias, and pancreatic carcinoma. Now, first of all, when we talk about cholestasis, it can lead to different types of jaundice. Jaundice with effect on the urine or stool color and serum levels of unconjugated bilirubin and conjugated bilirubin. Unconjugated bilirubin can't be urinated and is toxic in high amounts. Conjugated bilirubin can be urinated and is non-toxic. Now, the most important thing over here is the morphology. So what you would see is that the liver, skin, or sclera will turn yellow-green, and microscopically we will see the pooling of bile in the interstitium. Now, most common causes of jaundice, because we're obviously talking about jaundice over here, so the most common causes of jaundice would be hemolysis, obstruction, tumors, and liver diseases. So you can remember this with a hot liver. So in this case, we know that you've probably already studied about this, that we have prehepatic, hepatic, and post-hepatic jaundice. So prehepatic jaundice, in this case, we will have like unconjugated bilirubin will increase, and increased. This is due to increased hemolysis or due to transfusions, like autoimmune hemolytic anemia, for example. And then we have hepatic jaundice, in which we can have an increase in unconjugated bilirubin and conjugated bilirubin. This is due to, like, for example, impaired conjugation, like Crigler-Najjar syndrome, or there's some kind of liver damage, like viral alcoholic, non-alcoholic fatty liver disease, or Wilson's disease. There's impaired bile secretion in this case, like Dubin-Johnson syndrome, or there's high estrogen. And then there can be obviously intrahepatic cholestasis. Furthermore, we can talk about post-hepatic, in which there's an increase in obviously conjugated bilirubin, and mostly the etiology causing is like extrahepatic obstruction of the flow. Now, it can be, for example, cancer of the head of pancreas, or it can be cholangitis, which leads to swelling and obstruction. then which is leading to primary biliary cholangitis or primary sclerosing cholangitis, or stones like cholelithiasis or cholelithiasis, and or infections, for example, like liver flukes. There are some special cases in which we can have neonatal jaundice. Uh, it could be physiological if they still can't conjugate, or there can be, for example, erythroblastosis fetalis or kernicterus or biliary atrasias, for example, which we are going to be talking about. So let's start first of all with our biliary obstructions. Now, when you talk about biliary obstruction, most of the biliary obstructions are actually mostly extrahepatic. So this would come under the category of the extrahepatic biliary diseases. Now, in this cases, most common causes would be cholelithiasis, which is the most common. Then there can be tumors, cystic fibrosis in children, for example, or cholangitis, like inflammation and swelling, obviously, that which eventually leads to like we can say obstruction. Now, the obstruction actually leads to post-hepatic jaundice, inflammation, fibrosis, and if it persists, it can actually lead to cirrhosis and can lead to portal hypertension. Obviously, in the case that there is an obstruction, there's actually a higher risk of development of an ascending cholangitis. For example, if there's an obstruction over here, there's an obstruction over here, there's a high chance that because of the obstruction there can be like an infection which can spread upward, and that's what we're saying is basically ascending cholangitis, because there's no wash down, or it can be a carcinoma leading to because of the chronic inflammation. Now, Cholelithiasis are the stones in the common bile duct. Okay, so remember, cholelithiasis are within the common bile duct. Okay, within the common bile duct, where we would have this kind of reactive spasm, and so the patient would have colic pain. Then we talk about hepatolithiasis, which is common in Asia. These are like pigmented bilirubin stones. Okay. So next we can talk about ascending cholangitis. Ascending cholangitis is actually an acute infection by enteric bacteria, secondary to some kind of obstruction or stasis of the bile ducts. Now, symptoms in this case would be Charcot's triad, in which there is right upper quadrant pain. They would have jaundice and they would have fever. The treatment is normally antibiotics and drainage. However, there is a complication like sepsis that because of the high pressure in the duct, it pushes bacteria into the blood. So there's a chance the patient will have sepsis, and they can also develop liver abscesses. Furthermore, we can talk about biliary atrasias. Biliary atrasias are okay, so biliary atrasias are basically like obliterations or discontinuation, like a blind ending in this case. Okay, so we're talking about this blind ending which is present, and it can be fetal, like a genital, or it can be perinatal, like normal development damage occurs like following the birth. Now, in this case, it can lead to persistent neonatal jaundice, cholestasis, which can actually lead to cirrhosis and resulting portal hypertension. Now, the next ones that we're going to be talking about are primary biliary cholangitis. Now, most commonly, it is idiopathic, or it can be, for example, autoimmune. And we know that autoimmune diseases are more common within females. In this case, it is an idiopathic chronic inflammation and destruction of the intrahepatic biliary tracts that basically lead to cholestasis. Now, mechanism is autoimmune, like they say that it is autoimmune, or it can be idiopathic. Morphology is that there's actually a marked increase or marked early hepatomegaly. Okay, so remember, morphology is very important, and lymphoplasmocytic inflammation, fibrosis, and destruction of the duct. So the ducts are kind of like missing, and we can see these kind of granulomas, which are leading to cholestasis, which leads to hepatocellular necrosis, which leads to cirrhosis. So when we have cirrhosis, we know that the liver looks shrunken, and this normally occurs in the late stages. Furthermore, we can talk about primary sclerosing cholangitis. Now, primary sclerosing cholangitis, or we can see cirrhosis in this case. It is the idiopathic inflammation and fibrosis of the intrahepatic and extrahepatic biliary tracts. So the sclerosing type is also present in the extrahepatic. However, when we're talking about the biliary cholangitis, we're mainly talking about intrahepatic biliary tracts. Okay, so in sclerosing cholangitis, it leads to dilation of the preserved segments, and the risk factors is mainly in males, whereas biliary cholangitis was in females. Here we see it in males and in patients who have inflammatory bowel diseases, for example. There's an increased risk of biliary intraepithelial neoplasias and cholangiocarcinomas, for example, in the case of the patient's primary sclerosing cholangitis. Do make the relationship between biliary interepithelial neoplasias, because they can basically lead to it. It can increase the risk of it, and for example, cholangiocarcinomas as well. Now, morphology, what you would see in this case is that initially you would see that there would be fibrosis of the bile ducts and cholestasis, which basically leads to cirrhosis. This makes sense because what does sclerosing actually mean? Hardening, right? So what do we see? That the bile duct basically hardens, it becomes fibrotic, and then eventually it will lead to cirrhosis, right? Now, there are obviously some things that are very common between the primary sclerosing cholangitis and primary biliary cholangitis, like the symptoms. Like they normally start asymptomatic and then lead to cholestasis, which then leads to cirrhosis, and resulting it leads to portal hypertension. Furthermore, for the treatment, we can use bile acid replacement, steroids, or we can use liver transplantations depending on the state of the patient. Furthermore, we can talk about complications like malabsorptions, obviously cholestasis is present, so malabsorption is present, jaundice, and even cirrhosis. And actually we have the ability to grade these kind of grade these, we can say the cirrhosis. So it can be 1 to 4, 1 being lymphocytic infiltration and 4 being cirrhosis. At least know the 1 and 4 because they can ask you. You don't need to know all the classifications, but at least know that 1 is when there is lymphocyte infiltration and 4 is basically when there is cirrhosis. Now, we can also have secondary sclerosing cholangitis. So everything is already mentioned in the presentation. You can mention this, but it is not very important. Like in this case, there would be inflammation. So there would be like cholestasis, eventually, which will lead to damage, eventually, which will lead to fibrosis as a result of other etiologies like biliary obstructions, traumas, or pancreatitis. So it's basically sclerosing cholangitis, but it is secondary to some other etiology. Okay, so yeah, that's pretty much it. Thank you and all the best.